Welcome everyone for the class on neurology. So we'll be discussing neurological disorders today. The first thing we'll be seeing for the first thing we'll be discussing is about the headache. In headache, we'll be seeing the red flags. Why these red flags are important? Whenever you come across these red flags, we are thinking about a diagnosis which requires an immediate intervention. So there might be a life-threatening issue which is causing this headache, or it might require a CT scan because of the red flags are present. Or you might have to admit this patient, or you might have to urgently refer to some other specialty. So whenever there are red flags, you need to be aware that this patient might require a scan or further evaluation, or you might have to admit this patient for further evaluation. That's the reason red flags are important. So what kind of red flags we are looking for? Anyone with a thunderclap headache, suggestive of an subarachnoid hemorrhage, a new onset or change in headaches in patients who are aged more than 50 years, any focal neurological deficit, or other neurological deficits like higher motor function deficits like cognitive disturbance, or any abnormality on neurological examination. All these three are nothing but any neurological deficit if the patient has. Change in headache frequency. For example, this patient used to get a headache once in a month. Now he's getting every day. And it's bilateral. Before it was unilateral. Before it was not associated with vomiting. Now it is associated with vomiting. Headache that increases, the pain increases with change in posture. For example, when I'm sleeping, headache is better. When I get up, the headache becomes worse. So change in postures, the headache becomes worse. Headache wakes the patient up from the sleep. Headache increases with physical exertion or vascular maneuvers like coughing, laughing, straining while passing urine or while defecation. Patient with risk of cerebrovenous thrombosis, risk of cerebrovenous thrombosis will be discussing about mainly like pregnancy, OCP pills, dehydration are the main important risk factors for CVT. Jaw claudication and visual disturbances mainly suggestive of temporal arthritis. Neck stiffness, fever, think about meningitis, infection, meningitis, or encephalitis you're thinking about. New onset headache, especially in patients with HIV or anyone with a history of cancer, especially with history of cancer, if they come in with headache, you need to think, is this metastasis of cancer which is causing the headache? So these are all the red flag symptoms. Now we'll be discussing about different classification of headache. There are primary headaches and there are secondary headaches. What are primary headaches? In primary headaches, we don't have a cause for the headache. We don't know exactly what is going on here. Okay, this includes migraine, tension type of headache, cluster headache, some miscellaneous headaches like headache associated with sexual activity, headache on coughing, continuous coughing causing headache, headache on exertional activities. These are all primary. We call it primary because we don't know exactly what is the cause. The cause is unknown here. Why does a migraine occur? There are a lot of theories. None of them are proven why migraine happens. Tension type of headache. Why someone gets a tension type of headache? What is the pathophysiology? We don't know exactly what is happening here. Secondary headache. Secondary headache, as mentioned in this slide, which is filled up with this slide, or there are multiple causes. It might be traumatic, it might be vascular, like and bleeding inside the brain, inside the subarachnoid hemorrhage. It might be because of a thrombus formation in the sinus, or it might be post-lumbar puncture, or it might be because of certain infections like meningitis, sinusitis, some metabolic disorders. Even hypoglycemia can cause headache. Headache because of psychiatric disorders or some neurological involvement like trigeminal neuralgia. So there are various secondary headaches. Mainly we are put up to see that we know what is happening here. There is a bleed happening inside the brain. That's why this patient is having headache. There is an inflammation or the infection happening inside the brain, parenchyma. That's why you are having a headache. So we have an cause here. Here we don't have an cause. So each primary headaches and important secondary headaches we'll be discussing here. First one we'll be discussing about is a migraine. Migraine, how does a patient with a migraine present? A patient with a migraine usually presents with an unilateral headache. Unilateral headache will be pulsatile kind of nature, and it might last up to 2 to 3 days also. Sometimes it might be 1 hour, sometimes it might be 2 to 3 hours. The intensity will be around moderate to severe. It might be associated with nausea and vomiting. And if you take more history, the patient will tell you on exposure to bright light or exposure to noise, especially high pitched sounds, the pain becomes worse. It usually they'll have a past medical history of migraine. If you take in proper history, you'll have a past medical history of migraine. There might be a positive history of migraine also. What are the different kinds of migraines you're saying? There are different kinds of migraines. Not that every migraine has an aura, not that every migraine presents very typically. We'll see the different kinds of migraines now. Migraines without aura. There will be no aura at all. What is aura? Aura is basically they feel they're gonna have a headache. If you tell, sometimes in emergency, you must have seen patients, doctor, I'm gonna have migraine in some time. I feel like I'm gonna have migraine. Why do you feel? They're having flashes of light. They're having blind spots or any other visual changes, or they're having some tingling sensation in hands or face. Usually the patient will be able to pick it up that this symptom, when it comes, I know I'll be having migraine soon anytime. That is aura. 1/3 of the patients presents with an aura. So migraine with an aura, and few of them might not have the aura itself, they just might have headache. Few of them along with an headache, they will be having an unilateral weakness. Whenever they have a migraine type of headache, they'll be having a right upper limb and right lower limb weakness. Always remember that if this is an first episode, always rule out and stroke. Don't just assume this is a migraine. If it's a second episode, third episode, they have already met a neurologist. It's well documented that this patient is known to have hemiplegic migraine. Then you can assume and treat it symptomatically. Basilar migraine is similar to hemiplegic migraine, but the symptoms are of the posterior circulation. Here, the patient, along with an headache, posterior circulation symptoms like inability to walk, having a vertigo, dysmetria might be there. So those symptoms will present here. Acephalgic migraine, though described, very rarely seen. What is acephalgic migraine? Acephalgic migraine, here the patient doesn't has a migraine at all, typical migraine, doesn't have a typical headache at all. They present with other symptoms like aura. Very rest seen, less than 1% seen. This is more for the textbook theoretical purpose. These are the 4 different types what you need to remember. What are the triggers? Usually during menstruation, excessive binge drinking alcohol, on any oral hypertensive, oral contraceptive pills, stress, strenuous, unaccustomed exercises, certain foods like chocolate and cheese can trigger migraine. How do you manage someone presents with a migraine to the emergency department? Okay, treat them with triptans like sumatriptan and an NSAID. The combination of this, or a combination of oral triptans plus paracetamol. The route is important. Which route you are giving? Oral route you are giving. Triptans route is important. So oral route you are giving, you need to remember this, it's oral. In a teenager group, that is between 12 to 17 years of group, nasal triptan, that is intranasally you are giving triptans. That is the preferred route over the oral one. If it's a pregnant lady, only stick to paracetamol. Don't give other acute medicines unless there is a severe pain and you need to give paracetamol is not working. Then you can think of triptans. Otherwise, triptans are not preferred. Don't offer ergoids or opioids in an acute setting. Only preferred one are oral triptan plus NSAID or oral triptan plus paracetamol are the preferred ones. In pregnant ladies, we are giving paracetamol. Route you need to remember. SAH. SAH is very important. What is SAH? SAH is subacnoid hemorrhage. It's a bleeding in the subacnoid space, what you're seeing. Why is this important? Because this is life-threatening. Okay, if a patient is alive who is coming to an emergency department, if you miss it in few hours, he might die because of a massive bleed in subacnoid space. You might require coiling if the aneurysm bleed is happening in the arachnoid space. So if you get an immediate coiling done, you might reduce the morbidity and mortality in that patient. That's why picking up subacnoid hemorrhage is that important. Most of the time, there is an undiagnosed aneurysm in circle of Willis. Most of the time, it's at the anterior communicating artery, at the junction of middle and anterior communicating artery, or anterior cerebellar artery. This is the spot 40% of the aneurysms are present. It might be because of AV malformation, neoplasm, trauma, and angiomas, or myotic, that is infected aneurysmal ruptures. But most of the time, it is an aneurysm in circle of Willis which causes the bleeding. What are the risk factors? Mainly these risk factors, if you see, they are the risk factors which predisposes for an aneurysm formation. For example, connective tissue disorders like Ehlers-Danlos syndrome, Marfan syndrome, coarctation of aorta, increased pressure in the arteries can cause aneurysm. Similarly, hypertension, increased pressure. Other things which important you need to remember is smoking, atherosclerosis, family history, and SAH. Even polycystic kidney disease is also a predisposing factor for a formation of aneurysm. Eventually, it can rupture and cause SAH. These are the risk factors what we are talking about. How does a patient with an SAH present? With an SAH patient usually presents with a severe headache. This headache usually they will describe as an lightning which might have struck, worst headache of his life, and it is back of the head occipital region. And the intensity is quite rapid. In acutely, within seconds, it has become very bad. There might be history of loss of consciousness. There might be history of low GCS. Okay, so this is loss of consciousness, low GCS. There might be history of neck pain, photophobia, vomiting. But important thing is the warning headaches, what you need to remember. A fundoscopy, typical what we see is a subhiatal retinal hemorrhage, what you can see. There might be some focal neurological deficit also. But anyone who presents to the emergency department with a worse headache of his life, very acute onset, within seconds he has a worse headache of his life, there might be associated loss of consciousness or low GCS, always think of SAH. What are warning headaches? Warning headaches with little bit of physical activity. For example, you just lifted your hand to pick a book from a shelf and you started noticing that you're having a headache occipital region. If someone gives this kind of history with this simple physical activity, if he has a headache, that means these are warning headaches for a possible subarachnoid hemorrhage in the future. These warning headaches, you need to pick it up. This is where you will save the life. If you can pick it up at this stage itself, then you can get what is the neurological intervention, what is required, and save the life. Most of the emergency physicians miss this, and catastrophe happens after a few days, and they end up having a case with the corona. What are the investigations? You are suspecting an SAH because there is a very severe headache occipital region. So typically you're suspecting an SAH, what to evaluate or what investigation needs to be done. Get an CT brain done. CT brain, most of the time it should be able to pick it up. What you're seeing right in between the spaces is nothing but subarachnoid space, and this is SAH. It's supposed to appear like a frog like this. So it's supposed to be, this looks like a head and this looks like arms and legs, and this, the middle part supposed to look like a body, like a frog. So frog appearance, the typical appearance, what we call it. So get NCT brain done for everyone. In very few literatures, they see now the CT scans are so good that they pick up everything if they get in CT scan done within the 6 hours. After 6 hours, they're not very sensitive to pick all the SAH. This we don't advise you to follow, though Bromley tells it, because still there is evidence which is lacking. There still research is required. So we don't recommend you to remember this one. Always get an CT scan done whoever presents in SH. Remember that CT scan just can rule in, but can't rule out, cannot rule out an SH. If you're thinking of an SH, you got an CT scan done, it is normal. Still, you need to admit this patient. Why to admit this patient? Admit this patient to get an lumbar puncture done. You might be asking, doctor, why can't I get a lumbar puncture done in the ED itself? Because lumbar puncture needs to be done after 12 hours of onset of headache. If you do it before 12 hours of onset of headache, it is useless because it requires minimum of 12 hours for xanthochromia to appear in the CSF. This is nothing but RBCs when they leak the hemoglobin and all, which is results in a color formation of the CSF. CSF color is changed. It looks more yellowish in color rather than clear, which is normal. It looks more yellowish in color as you see here. So for this change to occur, it takes 12 hours. This is known as xanthochromia. This is the important lumbar puncture finding, what you need to remember here. Opening pressure will be increased because there is bleed in SAH, so overall pressure will be high. There is no bacteria, gram staining will be negative. Elevated proteins might be present. WBC occasionally, glucose normal. So two important points here: raised intracranial pressure, that is opening pressure of the CSF, and xanthochromia. These are the two things what you need to remember in the lumbar puncture. If you don't remember this, it's okay. It's not very important. It is done after 12 hours of onset of the headache. That also you need to remember, very important. There is classification. One is Hunt-Hess grading system. Another one is World Federation of Neurological Surgeons classification. Why we do an SAH a classification? Because this shows us the prognosis. This classification helps us to explain the relatives. What's the prognosis? What might be the prognosis of this patient? Someone with SAH presents with a coma, the prognosis very poor. The mortality rate is very, very high. Similarly, here grade 5 mortality rate is very high. So let's go through this Hunt-Hess grading and the World Federation of Neurological Surgeons grading. Grade 1 to 5 we have. In this, there is asymptomatic or mild headaches they are having. Grade 2, moderate to severe headache, or there might be a third cranial nerve involvement. Okay, oculomotor nerve, which is a third cranial nerve, there might be an involvement. In stage 3, slightly confused, drowsy, mild focal neuralgia. This way the CNS symptoms starts coming in along with the headache. 4, the patient is stuporous. He doesn't respond. Only for the painful stimulus he is localizing. He's completely comatized in stage 5. Same thing here. It is more quantified in the GCS form with a motor deficit. GCS 15 is grade 1. 13 to 14 is grade 2. 13 to 14 with presence of a motor deficit is grade 3. Grade 4 is GCS 7 to 12. Grade 5 is 3 to 6. Motor deficit might be present or may not be present, not important. GCS is the important. To differentiate between grade 2 and 3, motor deficits are important. What is the treatment? You can't do much about it for an SAH rather than involve a neurosurgeon and ask whether you'll take up for OT or not. So you'll be going according to airway, breathing, circulation, deformity, and intervene accordingly here. The interventions will be similar to what we thought for prevention of secondary brain injury in trauma cases. So in airway, if airway is not patent, you'll intervene. If PaO2 is not maintained, then you'll intervene, give oxygen if required, intubate this patient, maintain in the normal range. Similarly, PCaO2 maintain in the normal range. MAP, you'll be maintaining around 80. Okay, if there is a seizures, then you'll be treating with benzodiazepines. So these are the simple things what you'll be doing here. Then you'll be referring to neurosurgeon on an emergency basis. Nimodipine. Nimodipine is nothing but a calcium channel blocker. It is nothing but a vasodilator. Why do we use this vasodilator? We give this only on advice of neurosurgeons. Why do we give it? It causes severe cerebral vasospasm. What happens if there is an SAH? SAH means aneurysm. There might be bleeding from the aneurysm. The artery proximal to it undergoes vasoconstriction. Why? To prevent more bleeding, there is a vasoconstriction. This vasoconstriction will be so severe that it can lead to an infarction. To prevent this infarction, we give an vasodilator, that is a calcium channel blocker, nimodipine 60 mg per oral. This is a tablet what we'll be giving on advice of neurosurgeon. Mannitol to reduce the intracranial pressure, again on advice of neurosurgeon. The next important thing you need to remember is complications of SAH. What are the complications of SAH? There might be rebleeding. Okay, similar aneurysm might start rebleeding. hydrocephalus, lot of bleeding can cause dilatation of the ventricle, resulting in hydrocephalus. Cerebral vasospasm, I explained you. This is one of the most common complication, SIADH. Okay, SIADH, why it causes, no one knows it, but it leads to hyponatremia. So any insult to the brain parenchyma can cause SIADH, leads to hyponatremia, syndrome of inappropriate antidiuretic hormone. So there is no diuresis, this antidiuretic, so retaining water. So there is dilutional hyponatremia, what is happening here. There can be neurological pulmonary edema in these cases because of increased secretion of catecholamines. There is myocardial infarction can happen. This myocardial infarction leads to pulmonary edema. This is known as neurogenic pulmonary edema. So these are the complications of SAH, what you need to be aware of. Anyone has any questions still here can ask me now.
السلام عليكم.
Pregnancy.
Can you explain why pulmonary edema happen as a complication of SAH?
It's usually a complication of left ventricular failure. Left ventricular failure might happen because of catecholamine. Excessive catecholamines can cause myocardial infarction, which can cause left ventricular failure, which can lead to pulmonary edema. By itself, we can cause pulmonary edema in rare circumstances. Again, the exact pathophysiology is not known why. Any other questions before we go ahead?
Ramin?
Yes, please.
Management of migraine in pregnancy. Can you repeat it again? Management of migraine in pregnancy.
You'll stick to paracetamol. If at all paracetamol is not working itself and patient is in severe headache, asking for more painkillers, then you can go ahead with triptans.
Okay.
So benefits should weigh out the harm which can cause, then you are using triptans or you're sticking to paracetamol only. Tension headache. Tension headache is, as the name suggests, because of tension. Anyone is having tension, you are having a tension of exam, you can have a headache. Why does it happen? Don't know. So it isn't primary headache, what we call it. Okay, how does this usually presents as? They'll complain of bilateral headache, mostly in the temporal region and the frontal region. It's like a band. He'll say someone has tied a band around my frontal and temporal region and squeezing it. Usually it will be mild, sometimes it might be even moderate. There are no other associated symptoms. It doesn't get exaggerated by physical activities, doesn't get exaggerated by any flashing of the lights or increased sound. No. What you'll be doing, simple painkillers like paracetamol or NSAIDs, and you discharge them. Now admit any tension headache. Cluster headache. As the name suggests, it comes in clusters, small clusters. It lasts for 30 minutes and multiple clusters it will come. Okay. And recurrent multiple clusters, 30 minutes, and you'll be fine for 1 hour. Again, 30 minutes, severe headache. So this kinds of cluster, it comes. What is a typical presentation? Usually he will have a pain. He'll say pain is behind my ear, retroorbital plane. Behind my ear, the pain is, and it will be associated with symptoms like increased lacrimation, rhinorrhea, conjunctivitis or redness of the eyes, what you're seeing. So this symptoms association is very typical of cluster headache. So cluster headache, retroorbital headache, along with there will be increased lacrimation, increased rhinorrhea, and redness of the eye, especially the scleral region, and it appears in clusters of 30 minutes. There will be no aura, no vomiting, no photophobia, no photophonia. How do you treat? Treatment is important here because you can easily pick up a cluster headache. You can easily differentiate from a migraine, shouldn't be a problem. The normally used drug like triptan, paracetamol, NSAIDs, opiates, ergoids, all are not recommended. Oral triptans are not recommended. Okay. What we treat usually with, either we treat it with oxygen, one, or subcutaneous or intranasal triptans. The route is important. We're not treating orally here. Subcutaneous or nasal, this route is important. Don't forget, they will test you in the exam. How do we treat with an oxygen? Give them 100% of oxygen, at least 12 liters or 15 liters through a non-breathing mask. Once is better, you can provide an oxygen cylinder and discharge them. The other way to treat is by giving triptans. Triptans like sumatriptan you can give. Need not remember the doses. Route is important. So you are giving nasally or subcutaneously, which your hospital follows, but not orally. Orally are not effective, studies have shown. Okay, this is a non-breathing mask. They are giving high flow oxygen. Usually it is quite effective by just giving oxygen. So only two options, either oxygen you are giving or you are giving intranasal or subcutaneous triptan. So remember the route here. It is different from that of the migraine. Migraine you are giving orally, and in the teenage group you are giving intranasally. Here you're giving everyone intranasally or subcutaneous. What is temporal arteritis? Arteritis, inflammation. Of which artery? Temporal artery. So inflammation of the temporal artery is temporal arteritis. How does this patient presents with? The patient presents with headache in the temporal region, worse with jaw claudication. What is jaw claudication? Whenever there is movement of the jaws, increased movements of the jaws, the pain becomes worse. When do you do increased movements of the jaw? While having food, while chewing food, you will be moving your jaw a lot. Or if you're taking a lecture like what I am doing now, so you're moving your jaw a lot, that's when the headache will be worse. This is known as jaw claudication. One more symptom what you need to remember is scalp tenderness. Usually they'll say, while I comb my hairs, I have more pain. That is nothing but tenderness over the scalp because of that. Why it is important to pick up temporal arteritis? Because it can affect the optic nerve and cause blindness. They might completely lose their vision. How do they, how it affects? Any inflammation of optic nerve results in red desaturation. What is red desaturation? Red desaturation, if you ask the patient to differentiate between this, he will not be able to differentiate. Here we can see this is more vividly red. This is more pinkish in color. This is more orange in color. He will not be able to differentiate it. That is known as red desaturation. Relative afferent pupillary defect. That is, when you flash and light to the affected eye, it will remain dilated. It will not constrict. Okay, it is also known as Marcus gun pupil. All this temporal arteritis are 99% of the time associated with polymyalgia rheumatica. Polymyalgia rheumatica, as the name suggests, it is associated with some muscle aches, joint pains, weight loss. So it is an chronic disorder, and usually the patient who is having temporal arthritis will have an association with polymyalgia rheumatica. Don't forget this polymyalgia rheumatica. What investigations we can do from the emergency department? We can get inflammatory markers like ESR, CRP. Start them on steroids, usually 60 mg prednisone orally you will give, and you will either refer them or admit them depending on the local protocol to get a temporal artery biopsy. You need to refer ophthalmologist and rheumatologist, both of them. Rheumatologist mainly because they will be associated with polymyalgia rheumatica. Ophthalmologist because to get a biopsy done, along with an biopsy, eyes will be affected. They might be sometimes unilateral loss of vision. That's why ophthalmologists are involved. Some hospitals even involve oromaxillofacial surgeons to get the biopsy done. So it depends on the local protocol, what needs to be done. CVT, cerebral venous thrombosis. So in the venous system of the cerebral, there is a clot formation, thrombus formation. What are the predisposing factors for this? The important one is dehydration, pregnancy, estrogen containing OCP pills. Not all OCP pills, estrogen containing OCP pills are the important one. Rest are polycythemia. Again, it is more of an dehydration with, not dehydration, it is more of an increased concentration of RBCs. Thrombophilias, you can, nephrotic syndrome, where protein is lost a lot, more than 3+, and infections also can cause. But these are the important things what I mentioned, 3 important things, predisposing factors. Clinical features, headache, seizures. Okay, there might be other neurological deficits also along with the cranial nerve involvement. Okay, so for example, there might be third cranial nerve involvement. So it is difficult to differentiate from other headaches here. So when to suspect in CVT? there should be a risk factor. Either this patient history should be suggestive of dehydration, or in pregnant lady, or in lady who is on estrogen containing OCPs. Along with that, they have an headache, plus or minus seizures, plus or minus a focal neurological deficit. That's when you need to suspect and DVT suspect and CVT, cerebral venous thrombus, in the examination. For diagnosis, CT plain should be sufficient most of the time, or sometimes you might require a venogram. CT venogram might be required. How do you treat this? As it's a clot, you'll be giving low molecular weight like Lexin, that is enoxaparin, you'll be giving. Treat the underlying cause. If it's dehydrated, give him fluids, and if there is some other cause which is causing it, as discussed here, treat the underlying cause. Like meningitis, treat the underlying cause, meningitis. If the patient is having active seizures, you can give anti-epileptics. Preferred one for active seizures will be lorazepam. We'll be discussing more about this in the coming up slides. Medication overuse headache. These patients are on multiple pain medications. For example, he's on for 3 months, he is on either triptans, opiates, or ergoids, or he's on analgesia for 10 days per month in a month on combination anesthesia, combination of triptan plus opioid, or paracetamol and NSAIDs, or paracetamol, aspirin, NSAIDs, either alone or in combination for 15 days of a month or more. So basically, you need to remember this patient is on multiple painkiller drugs and he comes with headache. This basically is a term coined as medication overuse headache. What you will tell him: suddenly stop all the medication. Don't even taper it. Stop abruptly. Everything what you're taking, stop it immediately. Okay. Never admit this patient. Tell the headache will come down. Stop taking all this bunch of medications what you're taking. Everything will be fine. Take all those medications. Keep it with you. Tell him go back home. You will be fine. Don't admit this patient. That's what the NICE guideline says. Don't admit this patient. Trigeminal neuralgia. This patient presents with an pain which he describes like a shock. It's a shooting kind of pain. It feels like a shock what I'm getting it. Small things triggers it. Even someone blows air on my cheek, it triggers it and I get a shock type of pain. Okay, will be unilateral, and there sometimes there might be severe pain he might be telling. Sometimes it might be associated with some click sound or jaw stiffness also might be there, but mainly he will be describing like a shooting pain. What you need to remember, this will be the classical description of a trigeminal neuralgia. No investigations are required. It's a clinical diagnosis. Carbamazepine is a most commonly used one, but there are many approaches. There are many drugs they are using. So you can just remember carbamazepine, or according to the local protocol, I'll treat it. Shooting pain lasts for a few seconds, triggers by even an air or someone just touching the cheek or blowing an air. It gets triggered and it gets like a shocking kind of pain, lasts for only a few seconds. Typical history of trigeminal neuralgia, what you need to remember. Anyone has any questions can ask me before we enter into status epilepticus.
I have a question regarding the previous section, migraine. What is there regarding to protocol of adding metoclopramide or antiemetic or non-oral antiemetic with without non-steroidal for treatment of migraine, acute migraine?
Antiemetic, if the patient is having severe vomitings, you can add antiemetics. Okay, there is no specific indication on which antibiotic is preferred over other. Okay, you can give metoclopramide or encetron. Depending on your local protocols, you can give an antiemetic. Usually, if the headache subsides, the vomiting comes down. Advice or recommendation is to give either paracetamol plus triptan or an NSAID plus triptan.
Okay.
Doctor, for the medication-induced headache, you will not give the patient any medication?
No. It is mainly because he is taking multiple drugs. Because of that, he is having the headache. So stop them. The guideline says that stop them abruptly. So you will tell them, don't take any medication, no tapering down and all. You just stop taking all these medications what you are having. They'll be on at least 2 or 3 different kinds of medications for a longer time.
Even the patient worsening from the headache will not give anything?
No. If it's a medication overuse headache, just abruptly stop everything and send them home. If you give more medication, it will worsen the headache.
Dr. Amin, I want to ask about temporal arthritis. What age group are we expected to have this disease?
Usually in 20 to 40 years age group.
20 to 40, not very old.
Very old also can present. We can't really rule out on the age, but that is the age group. Little bit most commonly seen.
Okay, thank you.
Doctor, in this point, slide, sorry, you can repeat them. What about the red desaturation?
As you can see in this image below, what is here, this image below here, okay, you can differentiate. This is as pink, this is as orange, and this looks like a red. That means you are not having a red desaturation. If someone has a red desaturation, for example, if you are having a red desaturation, you will not be able to differentiate. He'll tell this is also red, this is also red, this is also red. There is no color difference at all.
Okay. Thank you.
Dr. Amin?
Yes.
Please, we talked about the subarachnoid hemorrhage, which is a question that comes almost every time in previous diets. There's general confusion between the difference between subarachnoid hemorrhage and vertebral artery dissection. It still came in the last diet, I think. So how do we properly differentiate between a vertebral artery dissection and the subarachnoid hemorrhage? Because they always bring something like the patients use shampoo.
We will discuss in the questions. We have the recall question. We'll discuss in that questions how to differentiate it and how to come to a diagnosis there. Okay, we'll come across those questions. It has appeared 2 to 3 times. We are aware of it. We'll discuss there.
Okay.
So we are going with the status epilepticus now. What is the traditional definition of status epilepticus? Any single seizure which is lasting for 30 minutes, or there were multiple seizures, but he has never gained his full consciousness in between the episodes, and which is lasting for more than 30 minutes, is known as status epilepticus. But do we wait for 30 minutes to say it is a status epilepticus and start the treatment? No. What we do is, if the seizure is lasting more than 5 minutes, we go ahead and start treating it as status epilepticus. Okay. Though the definition, this is the traditional definition, but we just wait for 5 minutes. If the seizures continue for 5 minutes, that means we are suspecting or expecting this to be an status epilepticus. If it has to subside, it should have subsided within 5 minutes. Usually 90% of the seizures will subside within 5 minutes. If it lasts longer than this without intervention, it will not subside. That's when you need to start intervening. What are the causes? If there is a previous history of epilepsy, most common cause is non-compliance with the drugs, or he has stopped taking, or he has withdrawn any drug, or there is a drug therapy alteration. He was taking one carbamazepine and he was shifted to phenytoin, and that might have triggered it. Okay. If there is no history of epilepsy, most of the time it will be either drug withdrawal, or there is an acute brain injury like a stroke or a trauma which has happened, or because of an inflammation, because of an infection, inflammation is there, or an abscess or an encephalitis, again, inflammation of the brain parenchyma, meningitis, meningitis. So that might have triggered and caused the status epilepticus. The most important thing from exam point of view is how do you treat it? Okay. When the remember that the clock starts when the seizure starts. Okay. If the seizure starts at home, you will assume the clock time starts from there itself. Okay. For example, if someone presents with 5 minutes of seizures, then you will not wait for another 5 minutes to start the medications. You already waited 5 minutes, because time taken for him to come from his house to the emergency department is 5 minutes. So you'll assume 5 minutes have been taken. So you will start with the medications. These are not very strict borderline. For example, someone with 40 minutes of seizures, I'll directly go ahead with an intubation. It's not very strictly defined on the time basis. Okay, it's a grossly, approximately they have defined how long can you wait after one intervention. It's a 10 minutes approximately. It's not a fixed time what they are telling you. How do you manage? First 5 minutes, what you'll be doing is an airway breathing circulation assessment. Start everyone with an high flow oxygen. Check for the glucose levels. Sometimes it might be just an hypoglycemic seizure what is having. If you just correct the glucose level, it will subside on itself. You waited for 5 minutes, still it is persistent. That's when you will give your first drug. First line of drug is lorazepam 0.1 mg per kg in children. Child, for adult, it is 4 mg per kg. In child, maximum we can use is 4 mg per kg. In adults, it is 4 mg per kg is the dose. Okay. If IV access is not available for some reason, then you can use diazepam 0.5 mg per kg per rectally you can use. Then you have waited for 10 minutes. So now the total time will be 15 minutes. So it's been 15 minutes since the onset of seizures, still not subsided. You will go ahead and use second dose of lorazepam. If IV access is not available, then you'll be giving parahaldiate 0.4 ml per kg mixed in equal volumes with olive oil per rectally you are giving. If IV access is not available, you should be having IV access by now. Do and venous cut down if required. It's another 10 minutes have already gone. So total is 25 minutes. Okay, total 25 minutes have gone. Still the patient is having active seizures. Involve the consultant if you are not already involved. If you don't have an IV access, at least get an IO or do an venous cut down, involve the anesthetic, whatever is required. You shouldn't be giving any reasons because it's already been 25 minutes. You should have an IV access. Then you'll be giving second line of drugs. These are known as second line of drugs. The preferred one nowadays is levetiracetam. Phenytoin, before we used to give it, the problem with phenytoin is it's a cardiotoxic drug. It requires enclosed cardiac monitoring. It can trigger arrhythmias. That's why phenytoin is not preferred. It has to be given over a time of 30 minutes. So slow infusion you have to do. If you rush it, it will cause cardiac arrhythmia. That's why it is not preferred. Levetiracetam, in that way, it's much safer drug. You can give it over in 10 minutes. You can give it much faster. It's a much safer. Doesn't require any cardiac monitoring. So levetiracetam has overtaken the latest recommendations here. Now you have waited another 15 minutes. So total time is 40 minutes. It's been 40 minutes. This patient is still seizing. So what you will do here? So you need to take over the airway now and you will intubate this patient. To intubate this patient for rapid sequential intubation, the preferred drug here for induction is, they might ask you a question on this, is thiopentol. Okay, thiopentol is the preferred drug. Why thiopentol is the preferred one? It's an barbiturate. Okay, barbiturates are powerful anti-epileptics. So they prefer this over other drugs to go ahead for induction. That completes and how to manage in an adult patient. For example, someone presents after 20 minutes of active seizures. So what you will do? You can always try giving a dose of lorazepam if it's not already given by paramedics. Then go for second line of drugs. Okay, you can just give lorazepam, wait for 5 minutes, not acting, then you can start on the second line of drug. Is someone who has been having active seizures for 1 hour and presents, his brain is already fried up. You go ahead and intubate these patients. So grossly, you can see the time and you can intervene, go in between the steps and intervene directly there. What about in children? It's quite similar in the children. Okay, it's just put up in an algorithm manner here. It is more clearly described in children's what needs to be done. It is quite similar to that of adults itself. Here, first you're doing for 5 minutes airway assessment, breathing assessment, circulation assessment, start on high flow oxygen, check for glucose level, treat if it is less than 3 millimoles. Usually seizures happens if it is less than 2.5 millimoles per liter. After 5 minutes, you can start with first line of drugs. Preferred one is lorazepam. If for some reason you're not getting an IV line or IO line, then you can go ahead with midazolam, Bakkali you can give. Then another 10 minutes you're waiting. After 10 to 15, that will be 15 minutes. Then you're giving second dose of lorazepam. Then you have waited for a long time. Another 10 minutes you have waited. That is around approximately 25 minutes till this patient is using second line of drugs. Preferred one is levetiracetam. Quite similar to that of the adult here we're talking. Now it is 40 minutes. What you have to do? Preferred one is go ahead and do a rapid sequential intubation. If rapid sequential intubation for some reason it's getting delayed, okay, then you can give alternative second line of drugs. What do I mean? You already given levetiracetam, then you can try giving phenobarbital, or you can try giving phenytoin by the time you are arranging or preparing yourself for a rapid sequential intubation. You can ask your nurse to give an phenytoin dose. Okay. Phenytoin, again, thiopentol is the preferred one, like in adults. If for some reason it is contraindicated because the patient is asthmatic or something like that, you can go ahead with propofol. Okay. If that is also contraindicated, ketamine, midazolam, there are different alternatives. You can go ahead if they are contraindicated. But the preferred one is, again, remains thiopentol. Go ahead with rapid sequential intubation. In most of these patients, if you get an ABG done, okay, this is more for you. I am telling, they might not test you in the examination. I have observed people going wrong here. I don't want to go wrong. Most of these cases will have acidosis. Both the components, metabolic, because there is increased metabolism, you're seizing, there is increased activity of the muscles. So oxygen supply will be hampered because he'll not be able to breathe because his respiratory muscles are also not coordinated. Respiratory muscles are not coordinating so that he can take adequate breaths. So there will be respiratory component also. Retained CO2 will be high and low bicarb levels will be seen. So it's a mixed metabolic acidosis you'll be seeing in seizures. This acidosis has an anticonvulsant property, and it doesn't correlate with the neurological injury at all. Don't treat this. Don't give any bicarb in this patient. Okay, it will not be helpful at all. Don't treat this acidosis. It will get corrected by itself. You need not do anything. It has an anticonvulsant property, so don't do anything about it. Investigations are similar for adult or child. All are directed towards the underlying cause to see what is the underlying cause. Is it an infection? Is it full blood count? Is it anything like an acidosis which is triggering this? Is it an electrolyte imbalance, hypoglycemia, electrolytes? If he is on anti-epileptic drugs, take the anti-epileptic drugs. Infection, take the cultures. If you're thinking of meningitis, get an LP done at a later stage. Toxic screening might be required. It might be withdrawal of some drugs, or it might be overdose of, for example, cocaine overdose can cause seizures. So it can be a cocaine overdose. So always get a toxicology screening done in this patient if you think there is no obvious cause on these investigations. So you're basically looking for underlying cause here. What is the underlying cause in this patient you're looking out for? What is first fit? When a person who is not known to have any seizures disorder comes with a first episode of seizures, we call it as an first fit. Okay. He says, doctor, I don't remember what happened. The one who is beside, it might be a wife or it might be a colleague, says he had and jerky movements of his hand and legs. There was urinary incontinence, bowel incontinence. There was a tongue bite, uprolling of the eyes. Typical history of generalized tonic-clonic seizures. And it lasted for 2 to 3 minutes. Then he was drowsy. Then he woke up. So typically suggestive of a seizure. What you will do? You will just rule out if there is any infective cause. Is there is any hypoglycemia which are caused, or is there is any electrolyte imbalance which is causing it. 12-lead ECG is always required because sometimes arrhythmias can mimic as in seizures. Someone having an VT can look like an seizures. So always we'll get an ECG done, but unlikely to be very typical of a seizure. Usually he will not have post-ictal drowsiness. Post-ictal drowsiness will be absent here. Okay, if the patient is febrile, we are doing again more screening for an infective parameters. If not, we will discharge him. So all these patients are discharged to first fit clinic. There is something known as first fit clinic where neurology, it's run by a neurologist. So you will be referring to the first fit clinic. There the neurologist will evaluate. If required, he will get an imaging like MRI scan done. So no imaging is required from emergency department. Let me repeat it. No imaging is required from emergency department. No imaging. Along with this, you need to remember that no prophylactic anti-epileptics are also required. I know in India or in most of the other countries, they give prophylactic anti-epileptics. No prophylactic anti-epileptics are recommended. While discharging this home, you should make sure there is a responsible adult for next 24 hours. Okay, you need to explain that responsible adult how to recognize this seizures if at all it occurs and get back to the emergency department. He shouldn't drive. till he meets up with the first fit clinic. That's when DVLA comes in. We'll discuss about it at the end. And you need to get that is first fit clinic appointment within the 2 weeks. So this advises you need to queue. At the same time, along with the driving, you need to explain the patient that he shouldn't work with any heavy machineries till he go and meets up with a first fit clinic. They will do further evaluation and give further advice. Any doubts till now, you can ask me before we go into stroke. So we will go ahead with the stroke. Stroke defines as, what does stroke define as? Stroke is defined by WHO as symptoms lasting for more than 24 hours. So it should last for more than 24 hours, then only we label it as a stroke. Otherwise, it is not a stroke. It will be an TIF from definition from a WHO. Stroke can be two kinds. It might be because of ischemia, that is reduced blood supply. It might be a venous thrombus which is causing it, or because of an emboli, or it might be because of an hemorrhage, because of a bleeding which has caused this one. Okay, there are two kinds of strokes, ischemic or hemorrhagic. The management are too drastically apart. Okay, so you need to pick up whether it's an ischemic or hemorrhagic before you think about management. So there is MCA territory, we call it, that is nothing but middle cerebral artery. So it might have been affected. We are basically talking about ischemic stroke now. Or it might be an anterior cerebral artery. This is the anterior cerebral artery. This is a middle cerebral artery. This is a posterior cerebral artery. Or this is a vertebral, these two are vertebral arteries which joins together to form an basilar artery. Depending on which artery is involved, the symptoms differ, they can test you on. Okay, so a little bit of anatomy before we dive into the management of acute stroke. Midbrain. Midbrain basically supplies the lateral part or lateral half of the brain. Okay, the medial half of the brain is supplied by the anterior cerebral artery. What is middle cerebral artery? You can see here, the lateral part of the brain mainly supplies the face and the upper limb. Medial part mainly supplies the lower limb. Okay, medial is supplied by anterior cerebral artery. This is supplied by medial cerebral artery. So let's talk about medial cerebral artery now. So we all know that brain communicates with the body on the collateral side. That is, if the right brain is affected, left side of the body will be affected. So right brain controls the left side of the body. So we'll be having weakness in left upper limb and lower limb. This is known as contralateral. So we'll be having contralateral motor deficit and contralateral sensory deficit. But from this image, we know that it supplies more on the lateral side. So face and face and upper limbs are affected more compared to that of the legs. Gaze will be deviated towards the lesion side. This is one important point. Gaze will be deviated towards the lesion side. Okay, if dominant hemisphere is involved, there might be an expressive dysphagia. If a non-dominant hemisphere is involved, there might be inattention or neglect might be there. We'll talk about neglect more in coming up slides. Or let me just see, neglect is different from that of the loss of vision. Okay, loss of vision, you're not able to see on that side. Neglect, basically whatever is there on that side, you are just neglecting it. It's not that he can't see it, he just neglects that side. So two things are different. Loss of vision and neglect are different. If they mention neglect, it is not loss of vision, or there's nothing wrong with the eyes. Anterior cerebral artery, as I told you, it supplies more of the middle part. Okay, so contralateral motor deficit, more of the legs are involved, more of the lower limbs are involved compared to the upper limbs, and there is sensory loss also. Thing you need to remember here is there might be some altered mental status, speech preservation and disinhibition. Mainly a cognition might be involved here, because they're getting involved is the frontal part also slightly will be involved in the anterior part. Frontal is required for your upper motor functions, more like communication skills, how you behave. So there might be some behavioral changes you might see in this patient. This is anterior cerebral artery. Posterior cerebral artery. Posterior, this part of the brain here, visual cortex, we call it, vision will be lost. So visual disturbances will be there. The main symptom will be loss of vision or visual disturbances. The most classical presentation is contralateral homonymous hemianopsia. That means you will be seeing a vision like this. There will be loss. One side there will be temporal loss. Another side there will be half on the nasal side there will be loss. Okay, that's why it is known as homonymous hemianopsia. Hemianopsia, this is hemianopsia. Homonymous on the same side. Contralateral homonymous hemianopsia. This image, if you remember, you know what this means. Okay, so basically you need to remember that visual cortex is affected, so vision will be affected. Here, lower limbs will be affected more, and there might be some disinhibition might be there. Middle cortex, the upper limbs and the face will be affected more. That's what you need to remember here. Now we are going into brainstem, that is vertebral artery or basilar artery which are affected. Brainstem is required to maintain the balance. If that is lost, you might have vertigo. Okay, and most of the cranial nerves comes here. Okay, 3, 4, all those cranial nerves 3 and 4 comes in the midbrain. Then you have pons, then your middle pons, you have 5, 6, 7, 8. Then your medulla oblongata, where you have 9, 11 and 12 9, 10 and 12 cranial nerves comes here. So cranial nerve involvement. So if you're seeing in cranial nerve involvement, he's having a little bit of vertigo, dizziness, he is having, think of vertebrobasilar artery involvement. Along with that, on examination there will be cerebellar signs like dysdiadochokinesia, dysmetria, finger nose test he'll not be able to do, heel shin test he'll not be able to do. Those kinds of cerebellar signs also can be seen. There are two syndromes. One is Wallenberg syndrome and Weber's syndrome. Till now, they are not tested because they are given in your question banks and students were asking last time around. That's why we have included this time around. Okay, easy. What do you need to remember? It's a midbrain stroke. Weber syndrome is nothing but midbrain stroke. This is the midbrain which is involved. Which artery is usually posterior cerebral artery, branch of an posterior cerebral artery which supplies the midbrain will be affected. In the midbrain, there is a third cranial nerve, so third cranial nerve will get affected. Okay, so what are the symptoms they present? They will present with a third cranial nerve symptoms. There is ipsilateral eye, that is the same side which is affected because third cranial nerve nucleus is affected, so it will be ipsilateral third eye which will be affected. Eye will be in downwards and outwards position. So if this is, the pupil will be here, downwards and outwards position, and there will be slight amount of ptosis can also be present, and contralateral motor weakness will be there. This is nothing but Weber's syndrome. Midbrain is involved. When lateral medulla oblongata, this is medulla oblongata. What you're seeing in the green is medulla oblongata. If lateral part of the medulla oblongata is involved, then we call it as a Wallenberg syndrome. Okay. Here, PICA is involved. PICA is short form for posterior inferior cerebellar artery. Here, different cranial nerves are there. This is 8th, 9th, and 10th. Because of involvement of 8th cranial nerve, you'll be having vertigo and vomiting. Because of involvement of glossopharyngeal nerve, you'll be having hoarseness. Because of involvement of vagus nerve, you'll be having dysphagia. These are the symptoms which are classically present. So you can diagnose as Wallenberg syndrome. So silent features we have put up so that you can easily remember and easily pick up if at all if this question appears. Till now, they are not asked in the examination. Might appear because they are in your question bags like MSCM success, MSCM exam prep. They have these questions on them, so we are covering it. Rose's score. This is the score which is recommended by NICE to use it in emergency department. So this is very important. They will test you in the examination on this. Facial weakness, 1 point, arm weakness, 1 point, leg weakness, 1 point. All should be asymmetrical. Speech disturbances, 1 point. Visual field defect, 1 point. Loss of consciousness or syncope is -1 point because it can mimic a stroke that is known as Todd's palsy. Okay. Seizures-like activity. Seizures-like activity and seizures. Sorry, what I said is for the seizure activity. After a patient has a seizure, he might complain of a weakness, unilateral weakness, that is known as Todd's palsy. Loss of consciousness and syncope with a neurological deficit, usually it might be suggestive of an subarachnoid hemorrhage because alternative diagnoses are suggestive, -1 and -1 for Rose's score. Stroke is unlikely if the score is 0 or lower. If anything, if you have only 1 point, also stroke is likely. Okay. So what investigations you need to get it done if stroke is there? Investigation, what is recommended or what ideally needs to be get it done is an MRI scan done, or a CT scan with contrast, a non-plain CT scan with an angiography. CT angiography, you need to get it done. Why angiography? These are all latest guidelines. CT scan with an angiography, they are preferring a plain CT scan followed by CT scan with angiography is the latest recommendation. Okay, or you can get an MRI scan with an perfusion imaging to be done. Why you get this imaging done? If thrombectomy can be done in this patient, if the patient presents within 6 hours and you're thinking this patient is a suitable candidate for thrombectomy, then go ahead and get this imaging done. NIHS scoring, it's important. You need not remember the different components. No one can remember it. There are multiple, I think 14 different components are graded differently. There will be nurses who are trained to score this. So usually it's not your headache. You just need to see a mild score is less than 5. If there is a mild score, there are well chances that this patient can improve on himself. You need not thrombolyze. So thrombolysis is usually not recommended. It's a mild stroke or a severe stroke. If it's in severe stroke, if you thrombolize, it will lead to edema formation, which will lead to herniation, and which will herniation, that is nothing but uncal herniation, that will lead to a death. Okay, so in severe stroke, NIHS score of more than 25, don't thrombolize. You need to discuss it and document it why you are not thrombolizing. Okay, now we are coming into a treatment. Depending on the scan, we know what kind of stroke it is, whether it's an infarct or hemorrhage. First, we'll talk about infarct. Everyone gets an aspirin. If he's not able to swallow it, you give it rectally, but he gets an aspirin, or give it by an Rayleigh tube, or you give it by with a feeding tube. But everyone gets an aspirin unless this patient is known to have an anaphylaxis for aspirin. Otherwise, you give the aspirin. Thrombolysis. This is IV thrombolysis, intravenous thrombolysis we are talking about. Thrombolysis, what are the indications? This only been less than 4.5 hours and you have ruled out intracranial hemorrhage. Okay, then you will be giving altiplase is the preferred one. 0.9 mg per kg, maximum you can use is 90 mg. It is infused over 60 minutes. Before you start infusion, you give 10% of this bolus, then rest of the 90% you are infusing over 60 minutes. The maximum dose is 90, don't give more than 90 mg. What are the contraindications for thrombolysis? This contraindication holds good whenever you think of an thrombolysis. This is not specific for stroke. It holds good for other things also. If there is an seizure at onset or woke up symptoms, these are all basically specific for stroke. Okay, clinical presence suggestive of an SAH, then you're not doing it. From here, there are general indications. If the platelet count is low, an arterial puncture or non-compressible site or an LP was done within 7 days, there is an urinary tract or an GI tract bleeding in last 3 weeks, there is an stroke or intracranial surgery or a head injuries for last 3 months, a previous intracranial hemorrhage or brain tumor or AV malformation if it's present, if the diastolic pressure is more than 140. If more than 140, we can't do anything much. But if the diastolic pressure ideally, diastolic pressure should be less than 105 and systolic blood pressure should be less than 180. These are the ideal things as mentioned here. If it is somewhere, if the blood pressure is somewhere here, then you can go ahead and reduce it by giving labetalol. That is nothing but it becomes an hypertensive emergency. Reduce it. If the blood pressure comes down, then you can go ahead and thrombolyze this patient. Okay, what you can do is you can give maximum of 2 doses. 10 mg you will wait for 15 minutes, give 1 more dose and see whether the dose comes out. If it comes down, that means the blood pressure comes down, then you can go ahead and thrombolyze this patient. The latest thing which has been followed worldwide and it is started getting followed in NHS also is thrombectomy. Thrombectomy can be done up to 6 hours. Okay, in certain conditions it can be done up to 24 hours also. This is the reason you need to get NCT angiography done. I'll explain why. has to be an acute stroke, which is less than 6 hours onset. Along with it, you need to demonstrate on NCT angiography or MRI angiography that a proximal artery is involved. The problem with the thrombectomy is you put in catheter, the interventional radiologist will put in catheter and pass that catheter till that artery. If it's a very distal small artery, they can't go till that, a catheter can't pass till there and do a mechanical thrombectomy. If it's a proximal, if it's a main branch of MCA or MCA itself has clotted, then you can reach to the MCA and do a thrombectomy. So you need to demonstrate it. Basically, radiologist will say that proximal artery is involved. You can go ahead with thrombectomy. Okay. In 24 hours, within 24 hours, that is between 6 to 24 hours, what is the indication? If an MRI scan says, or if an CT scan, that is a brain imaging, what you have done, radiologist has to report that there is still on radiological imaging suggested that there is a salvageable brain. The brain tissue is not at dead. There is a salvageable brain is there. Then you can go ahead and still do a thrombectomy. So this is the latest technique. This is the latest guidelines given in your OHEM, also given in your NICE guideline 2022. Okay. So you need to remember, they might test you on the latest guidelines, what have come up. What is the treatment for hemorrhagic stroke? Treatment for hemorrhagic stroke, when to lower the blood pressure. Okay, the patient should present within 6 hours and has a systolic pressure around this range. Then you start giving the drug, and target should be less than 140, but don't reduce rapidly. Target should be to reduce around 60 over an hour's time. Systolic blood pressure we are talking about. If it is more than 6 hours, or if the blood pressure is more than 120, then decide case by case, take a clinical decision. There are no exact guidelines for that one. When not to reduce an blood pressure, when there is an underlying structural abnormality is there, for example, there is a tumor, AV malformation, or aneurysm, GCS score is less than 6, you are going to have an early evacuation of the hematoma. So you're directly shifting to the OT, then don't do it. There's a massive hematoma, poor prognosis. This patient is for palliative care. So basically DNR, palliative care. So no point in reducing the blood pressure in this situation. Transient ischemic stroke. These are symptoms which resolves within 24 hours. Do not get any imaging done. This is not very important point. You need to refer to a specialist, that is neurologist, within 24 hours and get an MRI scan done within 24 hours. So you're not offering any CT scan here. You're just referring to the specialist whose job is to get an MRI scan done within the 24 hours. Your job is to refer to the specialist within 24 hours and start them on aspirin. So they will be taking aspirin till they meet the specialist. So this ends everything about the stroke, from TIA to ischemic to the hemorrhagic stroke and different syndromes like Valen syndrome. Anyone has any questions, you can ask me now.
Doctor, for TIA, if the patient is present before 24 hours and the symptoms still, we will not do for him any image. We will wait to complete 24 hours. If the symptom and sign resolve, after that we will decide this TIA.
That's where your NIHS course comes in. If you remember, when I was discussing about NIHS score, if it is less than 5, this is most likely an TIA. That's why we don't go ahead and do thrombolysis. In these patients, we avoid doing thrombolysis, start him on aspirin, and we can, if the symptoms are still persistent, admit that patient. If by the time they have come to the emergency department, symptoms are resolved, you can discharge them to follow up with neurosurgeons and this neurologist, sorry. And this appointment should be within 24 hours.
So Ramin, time of thrombolysis from onset of the symptoms or at the arrival of ED?
Onset of the symptoms. From the onset of the symptoms, it should be less than 4.5 hours.
Can you say why is this for loss of consciousness and seizure by this one negative? Why negative -1?
Seizures can mimic a stroke. Okay, of post seizures, some patients, they're stroke mimics. They're different stroke mimics. Those most common ones are SAH and seizures. Okay, post seizures, few patients will have unilateral weakness mimicking a stroke. This is known as Todd's palsy. Okay, that's why we don't do it. Another stroke mimic is SIH. Due to the bleeding in the subarachnoid space, there might be focal neurological deficit, which might mimic as in stroke. So anyone who has a loss of consciousness, unlikely, see, why does anyone lose in loss of consciousness? If to lose in loss of consciousness, both cerebral hemispheres should be involved. In a stroke, have you seen anyone where both right MCA and left MCA strokes are involved? Okay, unlikely. Both cerebral hemispheres needs to be involved. If both cerebral hemispheres are not involved, only one cerebral hemisphere is involved, he will not lose his consciousness. So stroke can't cause loss of consciousness. Okay, it is nothing but, if I'm not wrong, reticular system, which handles the consciousness level. Reticular system represents bilaterally in the brain. So both the hemisphere needs to be involved for loss of consciousness.
Dr. Amin
Yes, please.
is asking if is the patient at stroke is can't take aspirin. Is any medication can take other than aspirin if he's have peptic ulcer disease or contraindicated to aspirin?
Aspirin is the preferred one. Only contraindication, what I can think as an absolute contraindication, is he's known to have anaphylaxis for aspirin. Usually what they do is, if aspirin is not, for example, he's already on aspirin. If he's on low dose of aspirin, he will increase to a higher dose of aspirin. He's already on higher dose of aspirin for some other indications, for like an MI is already on high dose of aspirin. Then you can add up a secondary anti-epileptic like clopidogrel. Okay, clopidogrel can be added secondary or the alternative to aspirin if there is an absolute contraindication.
300 milligram?
Usually 150 we prefer, but again 300 again depends from neurologist. There is no clear guidelines on how much clopidogrel to be given.
Okay.
Dr. Amin, is a TI multiple time admission and coming to hospital is need for admission?
When to admit a TIA? Okay, if someone comes with, he says, doctor, I had upper limb weakness and it has completely resolved, discharge them. Someone comes with upper limb weakness, he says, still I am having an upper limb weakness, he has it, admit. Okay, another indication for admission is if someone says, doctor, since yesterday I have been noticing that I have been having right upper limb weakness. It lasted for 5 minutes, resolves completely, and after a few hours again I had upper limb weakness and it lasted for 10 minutes, it resolved completely. I don't know what is happening, so I'm here. This is nothing but crescendo TIA, we call it. Crescendo TIA. This crescendo TIA needs admission because this suggests you that there is something wrong. It might be for example, an atrial fibrillation, which is throwing up clots, throwing up emboli, which is causing TIA. He might have stroke any point of time. Admit this patient. So these are the two indications to admit. Persistent symptoms, crescendo TIAs, multiple crescendo TIAs.
Dr. Amin?
Yes, please.
Can you explain the ABG part in the seizure when it is metabolic acidosis and when we should not be treated it?
Can you repeat your question?
The metabolic changes in seizure and why should not we be treated it?
Acidosis itself is an anti-convulsant property it has. Okay. Why is acidosis? Is because of the increased muscular activity what you're having. That is your metabolic part. Respiratory, you can't breathe normally when you are having seizures. Okay, they will hold their breaths. There is no much coordination with their respiratory muscles because of the active seizures. What is happening? Because of that, also there is carbon dioxide retention. Okay, studies have shown that carbon dioxide retention, that is high PSUO2 and low bicarb levels, are not harmful. It doesn't suggest you of any neurological deficit or prognosis. It doesn't carry anything. On the other hand, it is kind of protective against, acts like an anticonvulsant. That's why we don't give any bicarb or anything in an active seizure patient.
Okay, thank you.
Dr. Amin, lactic acid is useful to differentiate it between true convulsions or not. Sometimes patient give history not clear.
Pseudo convulsion and true convulsions, how to differentiate, if I'm not wrong, your question is. So how do you differentiate pseudo convulsion and true convulsions? True convulsions, I'm talking about generalized tonic-clonic seizures. The face will be deviated to one side, okay, and he'll be having jerky movements. There will be no arching of the back will be seen in true convulsions, and the patient will absolutely not remember the whole episode at all. In pseudo convulsions, usually the the head will not be turned towards one side. He'll be turning to and fro. It will be one side on the right side, one on the side on the left side, and it might be in the middle itself. Along with it, usually they're having an arching of the back when they're doing a pseudo convulsion, when they're pretending to have a convulsion. Okay, and the patient will remember the whole episode, and usually they'll not have any post-ictal drowsiness. Coming to the lactate level is a very crude method to differentiate it. Because of increased muscular activities, definitely in a generalized tonic-clonic seizures, usually lactate levels will be quite high. Okay, it doesn't mean in a pseudo seizures lactate levels will be high. Pseudo seizures, usually they'll have some psychiatric disorders because of the dehydration and because of the violent movements what they are doing. It might be mildly elevated in pseudo seizures also, but if grossly elevated, sometimes lactates are 10, 12, then you can say it is a seizure, not in pseudo seizures grossly, but it's a crude method to do it. So let's go ahead with motor weaknesses. Motor weakness can be because of upper motor, this brain involvement, stroke or tumors. Lower motor neurons, these are the lower motor neurons which emerges from the spinal cord, not from the brain. It might be because of Guillain-Barré syndrome, or it might be because of subacute combined degeneration of the cord. Neuromuscular junction, muscle nerve junction of this part, like myasthenia gravis. Muscle itself is affected, like Dickinson's muscular dystrophy. So there are various motor weaknesses can happen. Might be because upper motor, lower motor, or neuromuscular junction are at the level of muscle. We'll see few of them which are important now. Subacute combined degeneration of spinal cord. It's mainly because of vitamin B12 deficiency. They classically presents with an triad. So you need to remember the triad: extensor plantar, brisk knee jerk, and absent ankle jerk. This is the triad, if you remember, that should be sufficient for subacute combined degeneration of the spinal cord. Syringomyelia. Syringo itself is suggestive of a cavity. Myelia is nothing but spinal cord. So there is a cavity inside the spinal cord. So this cavity is in the center and it expands bilaterally. It starts expanding. Mainly, it starts compressing the spinothalamic tract. We know from our previous cases that spinothalamic tract supplies pain and temperature. It carries nerve fibers for pain and temperature. So as it compresses spinothalamic tract, pain and temperature will be lost. It will be lost bilaterally. Okay, and it will be like cape-like deformity. It's like an cape what you wear. It will be like that, and it will usually involve bilaterally. If these are upper limbs, both sides will be involved in a cape form. Both sides, pain and temperature will be lost, but the dorsal column will be intact. Guillain-Barré syndrome, very important from exam point of view. What happens in Guillain-Barré syndrome? This patient has an acute GE, that is gastroenteritis, caused by Campylobacter. What does body does? Body B cells, immunology, B cells, if you remember from immunology, they produce antibodies to kill this Campylobacter. So multiple antibodies are produced. This antibodies not only kills Campylobacter, this also goes and attacks the myelin sheath, peripheral nerves, myelin sheath, it goes and attacks. So it becomes auto-antibodies. So it is attacking its own body also, because the structure is quite similar to your myelin sheath. Also, you end up getting affected. This nerves also. Sorry, this nerves also. So peripheral nerves are involved. So they classically present as an ascending disorder. So it affects the lower limbs bilaterally and it ascends upwards. As it ascends upwards, there will be loss of reflexes. First ankle jerk will be gone, the knee jerk will be gone. It will keep ascending upwards. The diaphragm can get involved. Thus, when it becomes problematic. If you have lower limb weakness, it's okay. It will get healed by itself. We can relax. But If diaphragm get involved, then you're screwed because respiration is gone. You need to intubate this patient. That's when getting an forced vital capacity is important. Normal range is 60 to 70. Why we need to get it in the emergency department itself? Why? Why means you can just document it at least in the emergency department. It was 60 ml per kg, so that they have a baseline, so that they can always fall back and say, okay, in the emergency department 60. Now it has come down to 40 ml per kg. If it comes down below 20, that's when you're worried. That's when it requires, usually you go ahead and intubate this patient so that you take over the respiration. This patient can have any point of time respiratory arrest because of paralysis of diaphragm. Diaphragm is the important muscle for respiration. This question asked previously, it was taught, but many missed it. I don't want you guys to miss it. That's why I'm telling what is the important.
No voice.
No voice.
So we can't hear them.
No voice.
No voice.
Can everyone hear me now and see the screen?
Yes.
Yes.
Yes,
Okay.
yes.
We were in the lung function test when it got disconnected. Lung function test, why it is important? What we are looking for is forced vital capacity. Because as it ascends upwards, the diaphragm will be involved. Diaphragm is an, if not important, is not the important, it's one of the important muscles for respiration. If diaphragm gets involved, this patient can have acute respiratory arrest. Okay, that's why we tend to document in the emergency department itself forced vital capacity, so that you have a baseline. When this patient goes to an ward or ICU setup, they can always fall back to this baseline and keep comparing. Usually in ICU, they keep measuring this forced vital capacity every day, if not twice daily, to see how is the lung function, whether diaphragm is getting involved or not. If once the forced vital capacity dips, usually less than 20, if it dips, they go ahead prophylactically, they go ahead and intubate this patient. Preferred treatment is intravenous immunoglobulins. This is better than plasma exchange. The only advantage of plasma exchange is it's cheaper. So in developing or underdeveloped countries, they might go ahead with plasma exchange because it's cheaper. Otherwise, preferred one is intravenous immunoglobulins. A variant of Guillain-Barré syndrome is known as Miller-Fisher syndrome. It usually presents with a triad: loss of reflexes, ataxia, and ophthalmoplegia. Ataxia and loss of reflexes can also be seen in Guillain-Barré syndrome, but ophthalmoplegia is kind of specific for Miller-Fisher syndrome. It's a variant of GB syndrome. Hydrocephalus. Hydrocephalus is nothing but dilatation of ventricles. It might be because there is an obstruction. We know there are lateral ventricles, there is third ventricle and fourth ventricle. If these are communicating with each other, if there is some obstruction during the communication, then it is mainly non-communicating. Because of obstruction, hydrocephalus has happened. Or there is something fault in reabsorption of CSF. CSF gets reabsorbed and synthesized in normal physiology. If there is something which is causing problems with the reabsorption of CSF, that leads to increase in CSF levels, causes dilatation of the hydrocephalus or dilatation of the ventricles. Different types, we are not that bothered, not important from exam point of view. It's not our headache, it's a neurosurgeon's headache. Normal pressure hydrocephalus can present to the emergency department. They again present with an triad: they have gait abnormalities, they have dementia, urinary incontinence. Gait abnormalities, urinary incontinence, dementia is the triad for normal pressure hydrocephalus. The pressure within the ventricles is normal, but they are dilated. We don't know exactly why. That's why we call it as a normal pressure hydrocephalus. They present with a triad. Most of the time, when this patient present to the emergency department, it's because of some problem with their VP stent or LP stent. That is lumboperitoneal stent or ventroperitoneal stent. They tend to drain the CSF into the peritoneal cavity, or they may drain into the lumbar region so that more CSF what is there, or if there is an obstruction, it gets drained there and it's synthesized and the pressure comes down. This circuit might get obstructed because of a blockage or infection. Get an plain series done for this. That's all you need to remember. Get a plain series of x-rays done. There is shunt series. If you tell, radiographer will be aware of it. Get in shunt series, ask the radiologist whether there is an obstruction. If obstruction is there, involve the neurosurgeons. Otherwise, you can't do much about it. So takeaway point is shunt series, you need to get it done. Idiopathic intracranial hypertension is also similar or same thing as pseudotumor cerebri. Is also known as benign intracranial hypertension. Seen in females, usually presents with visual disturbances. For diagnosis, imaging is required. How do you treat this patient? You treat this patient by giving carbonic anhydrase inhibitors like acetazolamide. If that is not helping, then you can go ahead with repeated LPs. If visual symptoms are already present, symptoms are very rare, might require surgical decompression. The call is taken by neurosurgeons, not. From emergency treatment, you will be just giving acetazolamide. If required, rarely, very rarely, repeated LPs might be required. So for you, for exam purpose, just remember carbonic anhydrase acetazolamide is the preferred drug here. Sometimes they might ask you about Erb's palsy, about Clums's palsy. Mainly in primary, they'll test you. So we'll test very superficially here. Brachial plexus, we are aware if C5 and C6 roots are affected, or injury occurs to C5, C6 nerve roots, it can present the patient with something known as Vater's tip. This hand position, what you're seeing here, is known as Vater's tip. Okay. Clums's palsy. If C8 or T1 is affected, we call it as a Clums's palsy. Kind of claw, kind of hand will be there. This is what they might be associated with an Horner syndrome. Superficially, we are testing because this usually they test in primary. We're not expecting this to come in exam. Anyone has any questions can ask me now before we go into facial nerve palsy.
Sir, how to differentiate trigeminal neuralgia and CVA by physical examination on facial expression?
Trigeminal neuralgia is a pain which lasts for a few seconds and it's a shooting type of pain. That from an CVA, if you're asking cerebrovascular accident, they will be having a weakness. You are going for a Ross's criteria, a Ross's score. According to Ross's score, you'll see there will be some slurring of the speech, some visual defects, some upper limb weaknesses. So there are two different, totally different kinds of entity. Okay, they're totally kinds of, this is more often pain, what you're talking about. This is more often weakness in cerebrovascular accident, what you're thinking about.
Thank you.
We'll go ahead with lower motor neuron facial nerve palsy, vaguely known as Bell's palsy also, but it's not always Bell's palsy. So little bit anatomy here, facial nerve. Okay, the lower part of the face has bilateral representation in lower part of the face has only unilateral representation in the brain. Upper part has bilateral representation. Okay, whenever there is an upper motor neuron involvement, only the lower part of the face will be affected. Only this part of the face will be affected if it's an upper motor neuron, because this doesn't have a bilateral representation in the cortex, in the brain. Whenever there is And lower motor neuron, we talked about previously what is lower motor neuron. Whenever the lower motor neuron is lost, complete one half of the face will be affected. Now we are just talking about a lower motor neuron facial nerve palsy. Okay. For this lower motor neuron facial nerve palsy, there are various causes. The idiopathic one is known as Bell's palsy. It is the most commonest one. Sometimes it might be because of the infection, like an Lyme's disease. This is a target lesion. We'll be learning about Lyme disease. Or it might be because of otitis media. Or it might be because of an inflammation of the parotid gland, or a tumor of the parotid gland, or some other neurological deficit like in Guillain-Barré syndrome you can see, or in vestibular neuritis you can see, or these are vesicles, what you're seeing inside the air, and Ramsay's syndrome can be it. What is Ramsay's syndrome? It is caused, vesicles are suggestive of herpes infection, so it is caused by an herpes. So giving acyclovir will be helpful here. So this patient's Ramsay-Hunt syndrome, the previously said one, we usually give high steroids for everyone with a lower motor neuron palsy. Along with it, we'll add up an acyclovir. Acyclovir, because we are sure that it is caused by an herpes virus. So acyclovir will be helpful here. How does an lower motor neuron patient presents with? He will not be able to get any wrinkles on his forehead when he lifts his eyebrows. He will not be able to close his eyes tightly, so he can open his eye. There will be facial deviation. Sometimes there will be even drooling of the saliva, or when he's having food, the food particles might come out from the angle of the mouth. Okay, this is lower motor neuron, how it presents with. Now going further, management. We don't know exactly what causes it. I've seen there are no vesicles, there is no parotitis, no inner ear infection. There is no other obvious cause. Then we call it as a palsy, Bell's palsy, because it is an idiopathic. We don't know exactly what causing it. Most of the time we say viral, but studies have shown that giving steroids will be helpful. So what is the regimen? These are the two regimens where we give prednisone. Prednisone orally is sufficient. Is none of the steroids are superior than prednisone. Like few people give methyl prednisone, very high doses, not required. The regimen is either you give 50 mg daily for 10 days, or you can give tapered doses of 60 mg for a week and reduce it. You need not remember the regimens. You have to just remember you'll be giving prednisone for every patient with Bell's palsy. This is for adults. In children, it differs. In children, steroids are not helpful. Usually they will recover themselves completely without any deficit, usually in 2 to 3 weeks. So you'll give an appointment to follow up with GP after 2 to 3 weeks. This is important. In children, steroids are not required. In adults, steroids are required. Ramsay-Hunt syndrome is also important, where we add up acyclovir because it's an herpes infection. These points you need to remember, and how to differentiate between upper motor and lower motor, what explained here needs to be remembered regarding the facial nerve palsy. Transverse myelitis. Transverse, it extends from one side to other side of the cord. Myelitis, inflammation of the myelin sheath, what is involved here. So a segment of the spinal cord will be involved. Okay, it's a rare entity in UK and rare, never tested till now in the examination, rarely might appear in the exam. Tapes dorsalis, complication of syphilis. Syphilis itself has come down, so tapes dorsalis has also come down, so it has become a rare entity. What are the classical features? There will be some personality changes, ataxia, Robertson's pupil will be there. What is Robertson's pupil? When you flash light, the pupil will not constrict, so light reflex is absent. But during accommodation, that is when a far object, you'll ask the patient to fix to the far object, then you bring it closer to it. Usually eye converges and there is constriction of the pupil. Here, constriction of a pupil is intact. That is known as Robertson's pupil. There might be signs of posterior column. Posterior column is nothing but dorsal column. From our previous classes, we are sure, or we are aware that dorsal column supplies are mainly involved in vibration sensation and proprioception. Loss of proprioception will cause wide base gait and high stepping gait. As it's a complication of syphilis, we treat it as syphilis, give benzyl, benzathine, penicillin, 2.4 million units IM once weekly for 3 weeks. That will be the treatment here. Myasthenia. What is myasthenia? First, we'll see what is myasthenia. Okay, this you can imagine as a muscle ending. Okay, this you can think of a neuron. Okay. Usually neurons, when they communicate, they have receptors, acetylcholine receptors. Okay, when acetylcholine will go and get attached to it, what happens in myasthenia gravis is number of acetylcholine receptors will reduce. So how do you treat, or how a neurologist treats here? So they will make sure this acetylcholine which is there doesn't break down. So they give this acetylcholine receptors breakdowns from an cholinesterase. So they will give some drugs which inhibits this cholinesterase, and there is more amount of acetylcholine so that it can go and stimulate this receptors. What happens if you keep on stimulating these receptors? They become resistant. Okay, they will go resistant. There will be no action because acetylcholine is already binding to it. If you are giving more and more, it is already binding acetylcholine. If you give more, there will be no effect at all, and it can adversely start. Okay, the symptoms can start worsening. That is known as cholinergic symptom, cholinergic crisis. Here, over medication has happened. You're given over medication, so this acetylcholine went and binding these acetylcholine receptors, and they are not coming off itself because there's so much amount of acetylcholine. Or someone who is under medicated can also present with myasthenia crisis. Both symptoms are similar. Okay, you're under treating, so there is no stimulation at all. You're over treating, so it can't get stimulated. How to differentiate it? We will give entrophonium. If the symptoms improve, that means it's a myasthenia gravis. If the symptoms worsen, then it's a cholinergic crisis. How do you treat it? If it is myasthenia gravis, then you give drugs like neostigmine or peridostigmine and you treat it. If it's because of cholinergic crisis, anticholinergic drugs you are giving like an atropine. So they can present to an emergency department as a myasthenia crisis or cholinergic crisis. So you need to be aware how to differentiate it and how to treat it. Remember that when you're giving edrophonium, if it's a cholinergic crisis, there might be respiratory paralysis, apnea can occur. So be prepared to intubate these patients because giving edrophonium can cause respiratory arrest. So this is the differentiation between myasthenia crisis and cholinergic crisis. You need to be aware that, because if you start treating cholinergic crisis as a myasthenia crisis, then you will cause more harm. Vice versa also implies. So it is important to differentiate it. Last one, multiple sclerosis. Multiple sclerosis, they shouldn't be asking you the questions, but they started appearing. Not sure why. Because it's a difficult diagnosis, usually diagnosed by neurologists, not in the emergency department. What happens? It's an inflammatory disorder, affects the neuron, myelin sheath of the neuron, causing demyelination. Usually they are young females who present it, and it involves different parts of the neurological symptoms. Sometimes she can come with eye problems. Sometimes she can come with an lower limb weakness. So there are two complaints. Having an right-sided eye defect, left upper limb is involved, and right lower limb is involved. So it is not correlating at all. Different parts of the brain is involved. If this is a brain, there are different parts of the brains are involved at different times, and sometimes they can, without any treatment, get healed by themselves. Most common symptom is optic neuritis. As previously I told, in temporal arteritis, where optic nerve gets inflamed, that was nothing but optic neuritis. Marcus gun pupil will be present, as explained previously also. Compromise with color vision, that is nothing but red desaturation can be there. Okay, there might be subacute or acute vision loss itself if complete optic nerve is involved, and because of inflammation there might be pain also. Only way you can diagnose by getting an MRI scan done. Nothing much you can do in the emergency department, just refer to the neurologist. The last slide is about DVLA. This you need to go about it. We have given the complete slide to you. There is no shortcut. You need to remember it. The only thing what I can say is whatever in the red, you need not inform the DVLA. This differs. If there is an car or motorcycle you're driving, or less bus or lorry you are driving, it differs. How many years you are not allowed to drive, whether to notify or not to notify, it changes. It changes according to the symptoms of the stroke, multiple TIS after an percutaneous intervention in acute coronary syndrome. If acute coronary syndrome, no intervention was done. Hypoglycemia with awareness, hypoglycemia without awareness, cough, syncope, epilepsy, first fit, it changes. So you need to remember this. Take a printout of this or whatever, however you can remember it. Keep it for the before the exam so that you can revise this and go. Usually one question appears from this. This is very important. Anyone has any questions, you can ask me before we go into recall questions.
Doctor, excuse me, for the previous slide, the one like a patient after PCI 1 week not need not notify ولا يعني 1 week should notify and after that not notify ولا? Because I not understand.
1 week she's not allowed to drive. Next thing is whether you need to notify the DVLA or not. You need not notify the DVLA. The patient or you need not notify the DVLA. If he is a heavy vehicle driver, bus or lorry, he's not allowed to drive for 6 weeks. After that, they'll consider whether to give the license or not. He needs to be notified for the DVLA. The first thing what you mentioned is not to drive for how many months or days or weeks. Here you can see if there is an epilepsy, he is a known epilepsy or in multiple episodes of seizures are there, 1 year he's not allowed. For a heavy vehicle, it is 10 years. For in first seizure, it's 6 months. For heavy vehicle, it's 5 years. All things you need to notify DVLA. Either the patient notifies himself. If he refuses, then you as a doctor have the responsibility to notify the DVLA.
Assalamu alaikum.
Walaikum salam.
I want to ask about starting of prednisolone in Bell's palsy. There is some rule I just wrote before that once the signs or symptoms start more than 72 hours, no rule for prednisolone to start.
You're asking me if the patient presents within Bell's palsy after 72 hours, whether to start the steroids or not. You can start the steroids.
Yes.
Okay, this is an acyclovir where we usually comment. We will talk about acyclovir in chickenpox, and I will talk about in varicella zoster how to use acyclovir about that one. Prednisone, you can start it if there is a delayed presentation also.
Okay, I can start at any time when patient come with presentation of Bell's palsy.
Yes, if he's still having persistently deficit is there, if he presents after 24 hours also, you can start them. After 72 hours also, you can start them. Usually they'll present within 24 hours because anyone who has a facial weakness, they'll be worried and they'll present. Very unlikely they'll present after a day.
Okay, thank you.
Dr. Amin, clinically, like you were telling, how to differentiate between facial palsy and stroke if patient came with deviation of angle of mouth. And so we will check the loss of wrinkles.
The thing is whether he is able to close his eyelid or not, and the wrinkles are the two things which are more specific for the lower motor neurons, which will be seen in lower motor neuron when it is affected. If it's only restricted to the lower face, where there is only deviation of the face, is not able to blow the air with the closed lips, it's more suggestive. Only here it is restricted, then it is upper motor neuron involvement. Think about stroke here. Usually if MCA is involved, you can see this. If MCA territory is involved, facial deviation can be found there.
And if left eye is involved, left angle of mouth would be deviated. Like we will say, then it is left facial palsy.
Deviation will be opposite.
Deviation will be opposite. And affected eye.
If you can see here, this is known as deviation. If you can see, there is loss of wrinkling here. Okay. And his eyes, he is not able to completely close it. If he closes it, he'll be easily able to lift it up, and the face is deviated to the opposite side. The deviation here you can see is opposite side.
Yes. So we will say this is the right facial palsy.
Here in this picture, it's a right facial palsy, right?
Okay.
Okay, it's clear.
Doctor, if it's include the upper and lower both, this would the all side.
It includes this part and this part also, then we call it as a lower motor neuron palsy. If it includes only the lower part, this is the green part, what is there, then we call it as an upper motor neuron palsy. Any doubts before we go into the questions? Any more doubts, any confusions, you can ask me now. We'll go into the question and answers. We have a 40 years old female who presents with right-sided retroorbital pain since morning associated with watering of the eyes and nasal discharge. What's the diagnosis?
Cluster headache.
Cluster headache.
Treatment?
High flow oxygen.
High flow oxygen.
Good. We'll go for the next one here. We have a 13 years old boy with an unilateral left-sided headache, watering of the eyes. Best initial treatment for this patient. Again, it's the same diagnosis. And again, it's oxygen is the preferred drug here.
Doctor, but this, why not migraine?
It's a unilateral
Watering
headache.
of the
Migraine
eye.
is not associated with watering of the eye.
Okay.
Okay, watering of the eye, redness of the eye, nasal discharge, all are along with the headache. Then you need to always think of cluster headache.
But in the migraine, the patient will not complain eye pain.
No, that's how you differentiate. Eye-related symptoms or nose, that is increased discharge from the nose, or more specific for the cluster headache, is not seen in the migraine. In migraine, you will more see of an unilateral headache, which is pulsatile in nature, associated with the photophobia, phonophobia, and vomiting, nausea and vomiting. Here, there will be no nausea, there will be no vomiting, there will be no photophobia, there will be no phonophobia.
Dr. Amin, you need to evaluate it by ophthalmology for this eye symptoms before
Okay.
diagnosed as cluster headache.
It's a clinical diagnosis.
Sir,
Okay.
SpO2 should be normal in this
Why
case.
not مثلا differential this my patient have glaucoma or something?
Again, you need to know how do you present it. Glaucoma, you'll have a fixed pupil, mid-dilated fixed pupil, and they'll be having some systemic symptoms also, like nausea, vomiting, headache. So you need to see those symptoms, you'll differentiate it. You don't have a fixed pupil here, circumcorneal, again, we need to go to the other chapter here. So if this is an eye, if this is an pupil, it will be mid-dilated, okay, and it will be fixed. Pupil will be mid-dilated and fixed. And the erythema, what you're seeing, will be circumficial. It will be around the pupil. Redness will be seen. This is more for an glaucoma, what you're thinking about. Okay, again, there are symptoms which will help you to differentiate it. Here, he'll not have any visual disturbance. More often, just watering of the eyes and redness of the eyes, along with nasal discharge, might be there, along with an retroorbital eye. So you're more thinking of a cluster headache. Okay, coming to the next question, we have a 33 years old female in her one week postpartum presents with seizures. Okay, she is a postpartum 1 week presents with seizures. History of gradual onset of headache with unilateral upper limb weakness since 2 to 3 days. Vitally, she is completely stable. What might be the most likely diagnosis?
Venous thrombosis.
Can it
Venous
be an
thrombosis.
eclampsia?
No, there is no high blood pressure. There is no urine protein.
Okay, it
No
is
protein
not
urine, no high blood
preeclampsia or eclampsia.
Ischemic stroke.
It is not at all a tension headache.
CVT.
Ischemic.
As she is a
No,
female,
CVT.
and it is a gradual onset of headache, and along with the gradual onset of headache unilateral, we are thinking about CVT. CVT is the right answer here. Remember that eclampsia can happen even after delivery. Okay.
Delivery. Yes.
Even after delivery. What is the actual treatment of eclampsia? They say deliver the baby, but 40% of the cases presents after delivery eclampsia, but there will be previous history. There will be history of preeclampsia. They will be having high blood pressure. There will be proteinuria, significant proteinuria will be there. those symptoms will be present. Again, we'll discuss in the, we'll not deviate from neurology here. We have a 26 years old female. He felt he would fall from the chair because of severe vertigo, which is associated with stiffness. History of playing karate last night. What is the most likely diagnosis?
Basilar artery.
See, when do you suspect an basilar artery dissection? These symptoms, there should be some predisposing factors. Usually they'll say they had some sports which was quite physical. So physical sports, any sports where there is a contact between bodies, so physical sport, or usually they'll say they have gone to a saloon and they have washed their hairs. Okay, there is an image I'll show you. They usually, while washing their image, all the weight will be on the neck that can cause vertebral dissection or basilar artery dissection. So this you need to look out for in the stem of the question when you're picking up an vertebral or basilar artery dissection. So here it will be basilar artery dissection this patient is having. Okay, usually subarachnoid hemorrhage or AV malformation or intracerebral hemorrhages can happen, unlikely in a 26 years old, but there is a history of karate they are specifically given, so most likely is an basilar artery dissection. A man collapsed in the house in Empire State. He was seen by the GP 2 days ago for vertigo and headache. Vertigo persistent even after taking medication. Likely cause.
B.
Carbon monoxide poisoning.
Night hemorrhage.
The right answer here is it should be a posterior circulation stroke for this patient to have an vertigo. Okay, so we are selecting an basilar artery stroke here. The question is, why not an carbon monoxide poisoning? It is not carbon monoxide poisoning because collapse was today, but the symptoms are happening since last 2 days. Because the symptoms are happening last 2 days and GP has prescribed the medication, inspired medication, if the vertigo doesn't come down, that means we need to always think of, please mute. While answering, you can unmute, please mute. In spite of medications, vertigo is still persistent, then you need to think of central cause. To cause an vertigo, we have cerebral nerve symptoms, posterior circulation needs to be involved. That is either an posterior cerebral artery or vertebral artery or an basilar artery needs to be involved. So most likely diagnosis here is basilar artery stroke. This is how they wash their hairs in saloon in UK especially. They might be in your own country also. The pressure is over the neck that causes injury to the either vertebral artery or the basilar artery, which runs close to the spine. We have an elderly female who has an occipital headache, complaints of multiple episodes of vomiting, just had her hair washed in the saloon yesterday. What is the likely diagnosis? Vertebral artery dissection because of a saloon history what they have given. Okay. Usually if it has to be an subarachnoid hemorrhage, they will describe it as a severe worst headache of the life, severe headache of the life. That's how an SAH presents. Okay, this is more of an vertebral artery dissection. A 13 years old male seizing since 50 minutes. Is a known case of seizures on valproate. Dad has already given 1 dose of midazolam. On arrival to the ED, patient is still seizing. What's the likely next step?
Levetiracetam.
Lorazepam.
Patient 50 minutes.
50 minutes.
Duration is important. It's already been 50 minutes. Ideally, this patient should undergo a rapid sequential intubation using an thiopental. Okay, that is not given in the options. So we'll go slightly above the algorithm. We'll go for levetiracetam is the preferred second line of drug. Because first line of drug they are given. I am aware that 2 first line of drugs needs to be given. I mean, first line of drugs 2 times needs to be given. But here, looking at the time, 50 minutes, we can use levetiracetam. So clear?
Yes.
Now we are going to the next question here. 8 years old boy brought to the ED by parents. Complaints of facial weakness and difficulty in closing the eyes on the same side. No lesions over the ear. What is the diagnosis and treatment?
Bell's palsy.
Bell's palsy, oral
Follow up.
Follow up.
Last one, yeah. TB3 with
Don't give steroids in this age group, pediatric age group. No steroids. Adults, yes, steroids. If this same patient was 28 years old, then this would have been the right option. 80 years old female bought by
I have
by
a
her
question, please.
visual.
I have a question. So if
Yes.
you use steroids in pediatrics, let's say in a 12-year-old or 11, what will happen? What's the implication?
There is no use. Steroids itself will have their own side effects. So studies have shown that steroids have no role in pediatric age group Bell's palsy, so they don't recommend it. If you give steroids, invariably you're giving an unnecessary drug which carries side effects. You'll have side effects of steroids, might have side effects of steroids. So you might cause more harm to this patient than causing good.
Okay, thanks.
no role for physiotherapy.
Physiotherapy, you can muzzle this one physiotherapist, you can refer them to physiotherapist. Then again, eye care, everyone with this needs to have an eye care because they'll not be able to completely close their eyelid. So some lubricating eye patch, you need to advise them. So usually we tend to refer to ophthalmologist also. We have an 80 years old female brought by her family with visual hallucinations. She says she sees people in her bedroom and she is known case of macular degeneration. Her cognition exam was normal. All other examination were within normal limits. What's the most likely diagnosis here? This is an difficult, which appeared, I think 2 days back, it has appeared. Here, the right answer is
Charles-Bonnet syndrome.
Yeah, Charles-Bonnet syndrome. Charles-Bonnet syndrome is a psychophysical visual disturbance. Okay, it's a psychophysical visual disturbance, what you're seeing here. What happens here is there is a severe blindness experience they are having, partial or severe blindness experience they are having. Usually they will be having a macular degeneration. When they are having macular degeneration, they feel that they are having a severe loss of vision. Okay, and they start having visual hallucinations. That's why she started having visual hallucination. Whenever they are having macular degeneration, they start assuming that there are things around which are not there and she's not having the vision. There's a poor vision. That is known as CB syndrome. It's a very difficult one to answer correctly in the examination. The right answer is CB syndrome. That stands for Charles-Bonnet syndrome. It's a very difficult one. Even in the consultant level also, people will get it wrong. So it's a difficult one. Patient brought to the ED in ambulance with complaints of 2 back-to-back seizures, each one lasting for less than 5 minutes. No further episodes since 30 minutes. Complaints on examination, GCS is 6, hemorrhagic staple. What's the initial step in the management?
Intubation.
Low GCS, intubate this patient. Good. Elderly male came in the ambulance with 2 hours history of a weakness and a reduced sensation in a right arm and a right leg, and has expressive dysplasia and facial asymmetry. There is no loss of consciousness, syncope, visual disturbance, or seizure activity. Her past medical history includes a hypertension and AF, for which she is received DC cardioversion last year. What is the Rosier score? They are just asking about the scope.
3.
So right arm weakness 1, 2, 3.
Right arm, right leg, and
4.
4.
Okay,
Four.
right arm 1 carries 1 point, leg weakness carries another point, asymmetrical, facial asymmetrical weakness carries 1 point, dysphagia carries 1 point, so it is 4. We have a 45 years old male complaints of upper limb weakness which lasted for 30 minutes, has recovered completely. What advice do you give before discharging this patient? This is an TIA because recovered completely. So no driving for 1 month.
No driving for 1 month.
Yeah, it's 1 month. You need to go through the chart what we have provided. It other than remembering the chart, there is no other alternative. We have a 35 years old female who developed sudden onset of occipital headache associated with multiple episodes of vomiting. She is currently on OCP. She just had her hair washed in the local salon yesterday. What is the most likely diagnosis?
Vertebral artery.
Same question.
Why not SAH? Right answer is
Why
vertebral artery dissection, but you need to know why not SAH.
They mentioned already occipital headache.
Occipital headache.
Not severe headache.
worsening.
Not
Not say worsening headache.
okay. There is not a very severe headache what this patient, though it is an acute onset, it's not a very severe headache what this patient is having. Next thing you need to rule out is why it is not a venous sinus thrombosis. She is on OCP.
Current.
Usually this is slow onset. It will not be a sudden onset. When you're thinking of sudden onset, something sudden like an SIH, it should be, or in a vertebral artery dissection, it should be. Okay, it doesn't seem to be like that. Slow onset, it should be. I have been having headaches since 2-3 days. That kind of history is the venous sinus thrombosis, what you're seeing. Usually some cranial involvement will be there, or there will be a seizure. So it is not the right answer. Okay, you should be aware why it is not right answer. Next question might be on CVT. They might just change it. They might just remove this one, and instead of a sudden onset, they might be saying it's 2 to 3 days onset, then it will become an CVT. Okay, they just play around with the words. It will change the answer. So you need to know why it is not, why the options we have ruled out. Young female complains of lower limb weakness, had an history of a gastroenteritis a few days back. She took on the counter drugs. What's the most likely diagnosis?
Guillain-Barré.
What's the most common organism? Campylobacter. They might ask question on this. Remember Campylobacter. 34 years old male complains of numbness over the right side of the face. Image of the face is given. What is the most appropriate? So what is it? It's a
Start with oral
steroid.
Yeah, the right answer is discharge with oral steroids. Which side it is affected?
Right side.
Right side.
Because facial deviation is towards the opposite side. Wrinkle is act here. So it is and lower motor neuron affecting the right side, discharge with oral steroids. Again, DVLA question, first episodes of generalized tonic-clonic seizures he had. So first episode of seizures, 6 months is not allowed to try. We have a 40-year-old male who was diagnosed recently with schizophrenia, started on medication treatment, complaints of a neck spasm, but he's completely normal on examination. After 30 minutes, nurse informs you that he is still having neck spasm. This is an acute dystonia. This shouldn't have been here. We will discuss again. Procyclidine is the drug of choice. Diagnosis is acute dystonia. We'll discuss again this question in psychiatric chapter. These are the new questions. These are from last deck. Patients present with bilateral lower limb weakness, which worsens after exercise, exhausted after whole days of work. What is the most likely what is the most likely diagnosis here? Myasthenia gravis. Because of decreased amount of acetylcholine receptors, as increased activity increases, the weakness also worsens. If you ask him to take rest, slowly he will recover. Usually the first symptom what they present is with the ptosis. Okay, the ptosis is the first symptom, but they can vaguely present, they can ignore the ptosis and vaguely present like this also. Still it is an myasthenia gravis. A patient presents with the severe headache. CT scan shows an intracranial bleed it is. Blood pressure is 200 by 130. Which one of the following is right?
3.
Don't systolic blood pressure 150.
Reduce maybe not more than 60.
Not more than 60.
Our target is maintaining blood pressure less than 140, not this one. MAP is around 80 we want to maintain, not more than 100. Okay,
Yes.
Levetolol is given as a drug of choice, not only if the GCS is low here. Okay, reduce the BP not more than is the right answer. We have a 40 years old male came to the ED with the right upper limb weakness. The speech was non-coherent and neglect was present when the wife stood on the left side. What is the Rogers score here?
1, 2,
2,
3.
1.
2.
3.
Speech.
2. The answer is 2. Most of them selected 3. They thought neglect was present when the patient stood on the left side. They're clearly saying it's a neglect. It's not a visual disturbance. They thought it is a visual disturbance and they have selected 3. No, it was 2. The answer is 2, not 3. Okay, it's clear. Neglect is different. Neglect comes in NIHS scoring. If you've done an NIHS scoring, actually, if you're free and if you have time, there are online courses which are free. You can learn about NIHS scoring, how to do it. It will not test you, but it's a good to know how an NIHS scoring is done. It is important if you're seeing stroke patients and if you don't have a specialized stroke nurse with you.
Dr. Amin, if they will not mention, like when the wife was present, standing on the left side, just they wrote like the speech was non-coherent and neglect was there.
The visual
then-
problem and not neglect, no, sir.
Visual problem is not neglect. When they specifically mention neglect, that means it is a neglect. It's not a visual problem. Okay, the wordings are important. Okay, there are different kinds of wordings. They use it in NIHS scoring. So it's better you guys, if you're keen, I'm telling because they'll not test you. But sometimes in questions to pick it up, this will be easier. Because the one who was telling me he was confident it was 3. When I specifically asked what wordings were used, then he said neglect when the wife stood on the left side. Then because I do NIHS scoring myself, when I see a stroke case, I was aware of this neglect term. And it is 2 score. Neglect is not included in the Rosier score. It's not in visual disturbance.
Okay, sir.
Yep. The next question is patient presents with ascending weakness. You make a diagnosis of Guillain-Barré syndrome. Which one of the following is the most sensitive predictor of respiratory involvement?
FVC.
Number one.
Forced
Forced
vital capacity is the right one. Okay, this is the most sensitive one. Okay, peak expiratory flow rate. Peak expiratory flow is very easy. There is a device like this in asthma. I told you has an in asthma chapter. I said we'll be checking for peak expiratory flow. It's an alternative to FVC, but it is not as sensitive as FVC. FVC is the most sensitive one, but most practical one is to do an peak expiratory flow. Again, this question is more asking most sensitive one. That's why FVC is the right answer. Peak expiratory flow. If peak expiratory flow is most commonly done, but it's not as sensitive as FVC. Elderly female presented to the emergency department with the headache. On examination. GCS was 15. A CT image was done, and the image is shown here. Once the patient is back from the CT, her GCS has fallen down to 8. What will be the next step? What's the diagnosis?
Intubation?
Yes. GCS, rapidly falling GCS of 8 or less than 8. Go ahead and intubate. We are always, emergency physicians always think ABCD. Okay. We always think in this. Don't forget, in neurology chapter also, we are using ABCD. 25 years old female had developed a sudden onset of occipital headache associated with multiple episodes of vomiting. Patient is on OCP pills. She just had her ears washed in a local saloon yesterday. So which one you will go ahead?
CT angio.
CT angio, because here again we are thinking either basilar artery dissection or vertebral artery dissection. CT angio. If this patient, this was not given and gradual onset was given, what will be the answer?
CT
venogram will be more helpful one, because we are thinking of cerebrovenous thrombosis. Venous thrombosis, so venogram will become more important. Let's go with the next one here. Young adult male brought to the ED in ambulance, complaints of headache, vomiting, and high-grade fever. Has noticed in non-blanching glass all over the body from the last 2 days. You are suspecting meningitis and decide to do LP. What is the contraindication for LP? Again, this question should have been in the procedures we have put up here. Again, a rash all over the body will be the contraindication here. Respiratory insufficiency only in the child pediatric age group is the contraindication. Okay, even the seizures, if there is an active seizure, is a contraindication. Mainly because there might be an self-harm when there is an active seizure. You will not be able to do an LP for an obvious reason, because it is seizing, will not be cooperative. A purpuric rash all over the body is an indication, is a contraindication for LP. Again, we'll study in detail. There are nice guidelines on LP contraindications. We'll study when it comes across. Okay. We have a 70 years old female presented to the ED with right upper limb weakness and lower limb weakness, and she has complained of left-sided ocular vision loss. CT scan was normal. What is the most probable diagnosis?
Multiple.
They have a right upper limb,
I see hypertension.
left lower limb, so two different regions of the brain is involved, and there is loss of color vision. All this fits into multiple sclerosis. Only one thing which doesn't fit in is usually it is in middle age, young female. It is around 20s and 30s, 70 years, that doesn't fit. But keeping all these symptoms in mind, it more sounds like a multiple sclerosis. We can see an papillary edema. I'm not sure whether an image, few people have told image was there, retinal image, which was suggestive of a papillary edema. Few were said it was not there. But anyways, with the stem of the question itself, we can diagnose that it is a multiple sclerosis. Another question which has appeared was 45 years old female who brought to the ED with the history of fever and cough. She gives an history that her bout of cough, that after a bout of cough, she had a syncopal episode. The diagnosis as a cough-induced syncope was done. What is the next step involved in involving the DVLA?
Driving restriction.
6 months.
Yes.
Yeah, 6 months, and you need to notify to the DVLA if I'm not wrong. Those are the things. It is a difficult one. You need to notify, and you need to restrict for 6 months. Notify and restrict driving for 6 months. 8 years old, ongoing seizures. Mom has given 1 dose of buccal midazolam. Paramedics have given 1 dose of buccal midazolam and wrote to the emergency department. Next step.
First, lorazepam.
First dose of benzodiazepine is been given. Second dose of benzodiazepine also given. One is given by mom, another one is given by paramedics. So we are in the third stage now. Now we are giving second line of drugs. Second line of drugs, preferred one is levetiracetam. So right answer is levetiracetam. Clear?
Yes.
We have an IV drug abuser present to the emergency department. Complaints of headache, dizziness lasting for few days. In ED, patient has a seizure lasting for less than a minute. On examination, there is an unequal pupil. Likely cause. We think the likely cause here is subdural empyema. Let's see more about subdural empyema and cerebral abscess. Usually, to cause an subdural empyema or cerebral abscess, the patient should be immunocompromised, like either an IV drug abuser or uncontrolled diabetes or on some chemotherapy. Then only we are thinking of this abscess as empyema. Or there might be some history of a trauma, contamination of the scalp that might have caused infection there. The symptoms on both are quite similar, okay? But the symptoms of subdural empyema are quite similar to what are given in the stem of the question. Like dilated pupil will be there, headache will be there, seizures are there, okay? And if you search further, there was an article which was published recently in the Oxford Journal. It was quite similar presentation. There's nothing different. It was very much similar. That's why we think it is in subdural empyema over and cerebral abscess in this patient. Why we are thinking about an abscess or empyema? Because this is an IV drug abuser, has a headache and dizziness and seizures. That's the reason we are thinking more about an abscess or an empyema rather than an inflammation like an encephalitis. Okay, most likely it is in subdural empyema. Again, if anyone has more thing to add up for this, can come forward and add up, because we're not 100% sure about this answer, mainly because on the journal it was given and the symptoms more correlate. We are going with subdural empyema. This is a difficult question which had appeared last time. Anyone has any questions, you can ask me.
Yes, doctor.
Yes, please.
Regarding Bell's palsy, if patient uncontrolled diabetic and hypertension, can give prednisolone or worse?
Again, you need to see the benefits against this one. If it's a worst one, is not able to have food, also everything is coming out, then you can control his diabetes by using insulin, regular monitoring, and start him on steroids, then taper down the insulin what he is having. You can do those things.
Can give also oral acyclovir or not, just prednisolone?
Just prednisone, acyclovir only if it's Ramsay-Hunt syndrome. In Ramsay-Hunt syndrome, you see vesicle lesions in the ear. That will be a clinical diagnosis. If you see vesicle lesions in the ear, as I showed you here, then it is a Ramsay-Hunt syndrome. Then you will prescribe acyclovir along with the steroids. Otherwise, don't prescribe. Acyclovir is not recommended. These are the vesicle lesions what you're seeing in the ear. This is Ramsay-Hunt syndrome. In Ramsay, steroids and acyclovir. Any other questions?
Sir, I mean,
yes, please.
About DVLA, you must be memorize it, yes?
Yeah, you must memorize, because if you memorize, you'll get 1 mark. If you don't memorize, you'll not get that 1 mark. So choice is yours. People, if you see from my previous batch, there are at least around 20 to 25 people who have not passed with 3 to 4 marks. That 1 additional mark, you can get it from here. Okay. People have got 114 and failed. If you would have remembered this, would have got 1 more mark. For example, I'm giving. So you might pass. So always go ahead and just remember everything. There is no shortcut for this. You have to remember everything.
Okay, thank you.
Hello, Dr. Amin. For temporal arteritis, because of the risk of blindness, do you still give oral prednisolone, or can you give IV hydrocortisone initially?
Again, steroids, you give it orally or IV, they act similarly. Okay.
Okay. Secondly, the in migraine, can you still give aspirin 900 milligrams for treatment of migraine together with the oral triptan?
Now we are giving triptan plus NSAID or triptan plus paracetamol. That's the recommendation. Okay, no more aspirin, no more ergotamines, no more opioids.
Okay, thank you very much.
Okay, you're welcome. Anyone has any more questions? Okay, we'll stop here. Thank you, everyone.
Thank you.
Thank you.